We're going to continue, and this is the menu I have prepared for you. I hope that when you had lunch in San Francisco, it was more sophisticated than what I have outlined here. But in fact, what I'm going to talk about is this menu. So we're going to have a starter, a amuse-bouche, which is covering the basic principles for evaluating arthritis. Then we're going to have some traditional fare. We're going to cover osteoarthritis, rheumatoid arthritis, spondyloarthropathies, CPPT, and gout. Going to move on with some more exotic flavors, which include neuropathic joints, synovial osteochondromatosis, tenosynovial giant cell tumor, collagen vascular disease, and finally, to conclude, we're going to look at some more high-calorie, heavy fare, which is infection. Okay, let's get started. So just to give a background, so the key challenge frequently is to differentiate inflammatory and degenerative joint disease. So one thing that really helps is that in degenerative joint disease, you have too much bone, you have osteophytes, you have subchondral sclerosis. While in inflammatory arthropathies, there's usually always a component where bone is missing. So you have juxtaarticular osteopenia, you have focal erosions. So this is a typical finding associated with this. And if you look at the whole list of findings, you see that there's some overlap between inflammatory disorders and degenerative disorders, but some are fairly different. So you have soft tissue swelling, which is more extensive with inflammatory disease as with degenerative disease. You do have a fusion with both entities, degenerative disease and inflammatory disease. And there's always a component of synovitis also associated with degenerative disease. But the juxtaarticular osteopenia is very typical for rheumatoid arthritis, while you have osteophytes, sclerosis in degenerative disorders. Concentric joint space narrowing in inflammatory disorders is opposed to asymmetric joint space narrowing with degenerative disease. And while you have erosions and fluffy proliferative new bone formation, you may have sometimes cysts and calcifications with degenerative changes. So these are clearly very distinct entities, though degenerative disease has sometimes an inflammatory component as well. Now let's talk about osteoarthritis first. Now osteoarthritis is, for most of you, probably bread and butter. You see this all the time. What you may not see so frequently is the MR of degenerative joint disease. And it's important to really keep in mind that there are distinct features for osteoarthritis in degenerative disease. And these include, first of all, that you have extensive loss of cartilage, which you see here. Here you have the normal cartilage. Here you have extensive loss of cartilage. You also do have bone marrow edema pattern, which can be sometimes fairly extensive, which is shown at the tibia and anteriorly at the femur. And also the meniscus, the internal structures of the joint, also degenerate. And these include the meniscus, which is completely macerated and destroyed here. So you have these degenerative tears of the menisci. You may also have subchondral cysts, and keep in mind, degenerative disease can also affect the ligaments. So you may have ACL tears, which are degenerative. You may have mucoid degeneration. And again, look at this, you have quite substantial amounts of synovitis in this joint, and that is just simply osteoarthritis. Now, there are some caveats where we have problems differentiating degenerative disorders versus inflammatory disorders. And one of them is this erosive osteoarthritis, which is frequently or typically seen in older women, in middle-aged women. And this is the standard osteoarthritis. This is the erosive osteoarthritis. And you see that, okay, here you have your osteophytes. Here you have your subchondral sclerosis. Yet in erosive OA, you have these irregularities of the joint space. You have these focal collapse of subchondral bone, focal fractures of the subchondral bone. And this is probably where that comes from. It looks erosive because they're focal little tiny fractures of the bone, which really do look like erosions. So it looks very different. Sometimes it can be extremely tricky to differentiate erosive OA and psoriasis arthritis. Now, it helps if you look first of all at the soft tissues, and this is really what you see. You see these typical sausage digits. This is not something you find with erosive OA. You find these extensive soft tissue swellings. Also, overall, psoriasis looks much more aggressive than erosive OA. It has these really destructive changes. Bone here is missing really, and you have these bony proliferation, these fluffy bony proliferations, which are not really so typical for erosive OA. So this is how you differentiate it. Overall, the picture in psoriasis arthritis is much more traumatic, and the soft tissue swelling is different. Rheumatoid arthritis is really the most frequent inflammatory joint disorder, and it follows a very specific course. It starts, first of all, with soft tissue swelling, and you have these periarticular soft tissues swelling around the digits. It is not a sausage digit. This is a focal soft tissue swelling around the joint. And as there is more joint inflammation, as there's more perfusion of the joints, what you do see is periarticular osteopenia, just due to the fact that there's more vascularity, which really leads to a demineralization at the level of the joint. So you have this periarticular osteopenia. Keep in mind, this is Uncle Sam watching you, and you need this later on. And then as the disease continues, you see that there may be joint space narrowing, there may be subluxation, but one thing is very important. You have to look at this subchondral lamella. If you see this subchondral lamella here and you can follow it, but you see that you're actually losing it here, that it's gone here. So this tells you there's some erosion, very subtle erosion, and it's difficult to see these subtle erosions, but you have to follow the subchondral lamella. If it's gone, then this is a sign of really early erosive disease. And also keep in mind, the pannus tissue lives in the joint. The pannus tissue tries to destroy the joint, tries to eat up the bone, and it is stopped by the cartilage. The cartilage prevents really the destruction of the joint. But what the pannus tissue tries to find a way to destroy the joint, so it basically goes to these marginal areas which are not covered by cartilage, and then it really destroys these areas. And you see nicely this apple core, nearly apple core, like a destruction of the joint. So these are these typical marginal erosions in the bare areas which you see associated with rheumatoid arthritis. Joint as the disease progresses, you see more and more fusion also of the joints, and this is shown here where the whole carpal bones are really completely fused. And you may also see at later stages some secondary degenerative changes. This is a radiograph of a patient who has advanced rheumatoid arthritis of bilateral hip joints, and again highlighting the typical findings. You have bilateral joint involvement, so you have this diffuse central axial narrowing of the joint. This is not like an degenerative disease where it affects mostly the superlateral aspect. This affects the entire joint. You see these erosive changes, again, in these marginal areas here, the erosive changes. In the early stages, you don't see osteophytes, maybe later, but keep in mind that in these weight-bearing joints, as the disease progresses, as the joints are more and more loaded, you will find secondary degenerative changes overlying these inflammatory disorders. And keep in mind that there is a differential diagnosis for axial joint space narrowing. It's not only found with inflammatory arthropathies, it's also found with infection, with hemophilia, and also with CPPD. And another important issue is that as the disease progresses, as rheumatoid arthritis progresses, it affects also the cervical spine. Somehow it loves the cervical spine, and it loves especially the craniocervical junction. And it really destroys the ligaments. The pannus tissue destroys the ligaments, and there's atlantoaxial instability. If this is wider than 3 millimeters, then that's abnormal. And sometimes you only see it during flexion. And it's really critical that you should always get these flexion radiographs. So you will not see the instability typically in these standard radiographs. You may see vertebral subluxation, you may see erosive changes of the odontoid, of the spinous processes, and also one important and very critical complication is basilar invagination, where basically the dens migrates into the foramen magnum and can cause some major neurological damage. Juvenile idiopathic arthritis is quite different from adult rheumatoid arthritis because as the pannus tissue, as this inflammatory tissue destroys the bone, these young bones have the potential to really grow, to make up for these destructions. They can regrow, they can but what ends up is that the bones are relatively deformed. So you see the distal ulna, how deformed it is. You see that the bones, the carpal bones, look very different. And as the cartilage gets destroyed, these children may already have, at a very early age, may have secondary degenerative changes. This is a typical example of a cervical spine in a child with a juvenile idiopathic arthritis, where you see that there's growth abnormalities during the development. There's a decreased diameter of the vertebral bodies. You see that there's fusion of the facet joints. This is the unaffected, the lower spine. These are the unaffected areas. Here you can nicely appreciate these small diameters, which is really very typical for JIA. So you will see that in these patients as they grow older. Spondyloarthropathies are really three of them we have to keep in mind. We have to differentiate. That's psoriasis. We've already talked about psoriasis. It's reactive arthritis, and it's ankylosing spondylitis. And what's really typical about these entities is that you have, first of all, a lack of osteopenia. You don't have the typical juxtaarticular osteopenia you find with rheumatoid arthritis. And the other really important thing is that you have these fluffy proliferations here. It looks a little bit like this little dog here. So you have these fluffy proliferations around the joints. And the more florid, the more active the disease is, the more indistinct these proliferations are. This is now the full-blown picture of a patient with psoriasis arthritis, which is very active. So first of all, you have these extensive sausage digits, very extensive. So then note that there is a lack of juxtaarticular osteopenia. Also note there are these tiny, fluffy, proliferative changes right here, and there's also pretty significant erosions all over. Psoriasis loves the DIP joints, and it loves to affect the entire digit. So you see this type where it affects all the DIP joints, and the type where it affects longitudinally the whole finger. Reactive arthritis likes the lower extremity, and the joint which is particularly affected by reactive arthritis is the interphalangeal joint 1 at the foot. But you also see retrocalcaneal bursitis, which is shown here. You see these erosive changes, and again you see these fluffy proliferative changes at the calcaneus here, which is again this typical sign of these seronegative spondyloarthropathies. You also have findings at the spine, which are fairly characteristic, and these are these paravertebral ossifications. These are usually unilateral. They are non-marginal, and these patients may also have sacroiliitis, which typically is more asymmetric, but also frequently bilateral. And this is again showing these paravertebral ossifications or parasyndesmophytes, which are very distinctly different from the syndesmophytes you see with ankylosing spondylitis. Here you have your typical syndesmophytes, which are really along the outer border of the annulus fibrosus. And you also see, as there's inflammatory disease along the annulus fibrosus, there's also proliferative new bone formation along the anterior surface of the vertebral body. And this is what's called squaring, that results in squaring of the vertebral bodies. You also see in advanced disease these fusions of the SI joints, which are very typical. You see affection typically of the large joints. The ankylosing spondylitis likes the hips. It may eventually even fuse the hips, or it may cause significant secondary degenerative changes eventually. And these are more early stages of ankylosing spondylitis, where you have your shiny corners. That's how they call. That's where there's the inflammation, and that's where the little syndesmophytes arise from. So you have these little shiny corners, and the shiny corners are particularly well seen in MR images. And this is not degenerative disease, and this should not be confused with degenerative disease, degenerative end plate disease. These are little shiny corners which are signs of inflammation. The disc actually looks good. There's no degenerative end plate disease here. And more advanced disease, as everything fuses and there is reduced motion there. And you also have to keep in mind that ankylosing spondylitis severely demineralizes the bones, so the bones are not as stable. Fractures, stress fractures may occur. And these stress fractures can really progress and cause findings which look very much like discitis, osteomyelitis, but this is just an Anderson lesion or the stress fracture, which makes the whole spine relatively unstable, and these really need to be treated, and the spine needs to be stabilized because there's a high risk of instability. So these are these Anderson lesions which really are very destructive, very bad for the biomechanics. Now, in the early stages of sacroiliitis, you see that the iliac side is more affected than the sacral side because the iliac cartilage is thinner than the sacral cartilage. And then you may see a whole bunch of things happening. You see increased sclerosis, you see these focal erosions, and eventually narrowing of the joint, and you will eventually see fusion of the joint. Now, radiographs are not very sensitive to diagnose sacroiliitis, and really the most sensitive technique to date to diagnose sacroiliitis is really MR, where you see relatively early on these edematous changes, these irregularities along the SI joints. Also, keep in mind the differential diagnosis. We see sacroiliitis not only with ankylosing spondylitis, we also see it with psoriasis, with reactive arthritis, with inflammatory bowel disease, and with infection. CPPD, or crystal or calcium pyrophosphate deposition disease, is a disease which typically affects older patients. It's a deposition of these calcium crystals within the menisci, within the hyaline cartilage, but it can also be found all around the joints, in the ligaments everywhere, and it causes this typical type of osteoarthritis which affects the femorpatellar joint. So if you see really severe femorpatellar joint OA, you should always think of CPPD because it's just frequently related with CPPD. Standard MRI is not very good at picking up these calcium crystals, as can be seen here. This is a normal fast spin echo sequence of the joint compartment with the cartilage and the menisci, and it's really hard to see the crystals here. But gradient echo sequences actually really nicely show these calcium crystals, as can be shown here. And if there's a question about CPPD, which you're not going to see with your standard fast spin echo sequences, it's always a good idea to add on gradient echo sequences. Gout is a deposition disease of monosodium urate crystals, and it goes along with a asymmetric affection of the joints. It leads, usually the joint spaces are normal. There's usually also normal mineralization. There may be tophi and punched out erosions, and I think this is nicely illustrated in these images where you have this intraosseous tophus with calcifications Also very typical for chronic gout is really severe degenerative disease of the first MTP joint, which is shown here. And here nicely illustrated these soft tissue tophi, which are also eroding the bone. Again, soft tissue tophus with partial calcification, and nicely shown here, this overhanging edge in this tophus. These tophi can be pretty ubiquitous in the joint, and they can be quite in different regions. Sometimes they can even look like metastases or soft tissue tumors, such as here where you have soft tissue gout tophi just anterior to the patella tendon. So keep that in mind. If you see multiple of these tumor-like deposits, then gout is always an important differential diagnosis. Again, they may not only be found at the foot, they may also be found at the hands, like here where you have these gout tophi around the joints. So let's move on to some of the more exotic things, and neuropathic disease is the first one we're going to talk about. Neuropathic disease is most frequently seen with diabetes and at the foot. You see pretty destroyed joints. I mean, this is not just a inflammatory, slowly decaying joint. This is a completely destroyed joint where you have this destruction, sclerosis, you have debris, you have sometimes periosteal new bone formation. So this whole thing is really falling apart. And there's a hypertrophic type, which is more frequently found with diabetes, and there can be an atrophic type, which is found sometimes with syringomyelia. And there's bone resorption, which may look like there's resection of the bone. At the same time, the mineralization is relatively normal, and again, there's debris. This is an MR image where you see this sort of pseudo-surgical resection or destruction of the humeral head. There's a differential diagnosis for this, which you should have in mind. It's burned out inflammatory arthropathies, it could be burned out infection, or Gorham's disease. Synovial osteochondromatosis can be either secondary or primary. The primary type is found in younger patients and goes along with synovial metaplasia of the joint, of the cartilage. It may be most frequently found monoarticular. The knee is the most common site. And also what is really important is that not always do you see calcification. So the joint, the radiographs can look completely normal. You may not see calcifications in about two-thirds of the cases. Now, most of the time we see synovial osteochondromatosis related to secondary degenerative changes. It's secondary either to osteoarthritis, to cartilage loss, may be associated with avascular necrosis or osteochondritis dissecans. This is an example of a MR image which shows us primary synovial chondromatosis, which is really hard to differentiate from fluid, but you see this lobulated pattern. You see that this is not your typical fluid accumulation, it's a lobulated pattern, and this is how it looked like during arthroscopy. This, again, keep in mind, this did not contain any calcification, so the diagnosis may sometimes be quite tough. We've previously called it PVNS. Now the pathologists don't call it pigmented villonodular synovitis anymore. The pathologists call it tenosynovial giant cell tumors. And this is an entity which is usually found monoarticular and most frequently at the knee joint. And the patients that are affected by this entity are relatively young. They are in the order of 20 to 50 years. Usually there's no joint space narrowing, but there can be quite significant destructions at the joint. So you see that here, these soft tissue changes around the joint. You can see erosive changes, which are shown here. And you may see that there's hemosiderin in these areas. If you see synovial tumors, you should always have a differential diagnosis, which includes, of course, tenosynovial giant cell tumor. It also includes gout. It can be seen in rheumatoid arthritis, synovial hemangioma, and of course, synovial osteochondromatosis. That's your differential diagnosis if you have a tumor which is located in the joint. Rarely are malignant tumors really located in the joint. Another important thing is if you want to differentiate synovial osteochondromatosis and tenosynovial giant cell tumor, what really helps is to perform gradient echo sequences, because they really show these pluming artifacts where the hemosiderin, which is not really very well shown in these fast spin echo sequences, is really amplified, and you see these large pluming artifacts. Collagen vascular disease is an entity which is clinically, of course, very obvious. The patients have these typical clinical deformities of the fingers where the skin is really super thin. There's loss of soft tissues, and these patients will eventually, because there's a loss of perfusion, they will develop acroosteolysis. You see that there are erosive changes here, there's amputation here. One important finding is that they also have these subcutaneous calcifications, which you see here. That's a very classical finding. Okay, and let's go over infection. Finally, some heavy stuff at the end. We look at different types of infection. In these acute infections, which are most frequently due to Staphylococcus, we have some relatively typical clinical findings. These patients have really fever and they have severe pain. You see that the bone marrow is diffusely infiltrated by inflammatory tissue. There's inflammatory tissue along the cortex, and you see even that the periosteum here is elevated and there's pus formation underneath the periosteum, which will eventually give you an involucrum. Septic arthritis is typically monoarticular, and again, it shows much more involved changes than those you see with inflammatory arthropathy. There's a ton of edema. There's really severe erosive disease. There are large joint effusions, and the pattern may be quite uniform. There's juxtaarticular osteopenia, and eventually there's severe secondary degenerative disease. Now, the really tricky part are the subacute infections, Proteus abscess. These are the clinical findings in these patients are not very typical. They may be mild, the labs may frequently be negative, and they can be not infrequently, especially if they occur in younger patients, be misdiagnosed for entities like Langerhans cell histiocytosis, osteosarcoma, Ewing sarcoma, or osteoblast. And this is an example of a Proteus abscess where you see this osteolytic change in the distal tibia metaphysis, and it even bridges the joint here. Chronic infection shows extensive sclerosis and sometimes lytic areas in between, such as shown here, where you have really extensive cortical periosteal bone formation. You have deformity. You have sometimes a reactivation to acute inflammatory disorders, and sometimes chronic infection leads to malignant degeneration, where you have squamous cell tumors arising in these areas. There are some specific types, special types of osteomyelitis. One of them is the sclerosing type of osteomyelitis, or osteomyelitis of Garay, which is shown here, where the differential diagnosis towards lymphoma and metastasis can be tricky. Another important thing is to know about the complications of osteomyelitis, and these include slipped epiphysis, such as shown here, because there's so much inflammation. There can be AVN, which you see here, and there can be fractures because the bone is so weakened, and you see that there's diffuse infiltration, destruction of the cortex, and this eventually results in a fracture. There are some special types of osteomyelitis which I want you to make you familiar with, and one of them is chronic recurrent multifocal osteomyelitis. That can be very tricky. The diagnosis can be extremely challenging sometimes, And these patients have a subacute to chronic osteomyelitis where the cause is not really very well known. It causes multiple bones to be impacted, affected, involved. And here you have the ilium, which is involved. And the disease starts, it persists over a long time. It may go away, it may come back again. And when you see this typically in children, but you may also see it in adults. And very important is that if you biopsy these patients, the biopsy is really non-specific. So this is really a diagnosis of exclusion. It likes to affect the lower extremities, the tubular bones, and if it's the sort of subtype, which stands for synovitis, acne, pustulosis, hyperostosis, osteitis, it typically affects the medial ends of the clavicle. So SAPHO is really a subtype of chronic recurrent multifocal osteomyelitis. And the differential diagnosis can sometimes be tricky. One of the things to consider would be fibrous dysplasia and juvenile Paget's disease. Spinal tuberculosis is really the most frequent type of osseous of skeletal TB. It has an interesting course of disease. So it starts at the anterior part of the vertebral body adjacent to the end plate. It causes erosion, and then it causes scalloping of the anterior aspect of the vertebral bodies. And it can really affect, as it grows along, as it sort of infects the tissue along the anterior longitudinal ligament, it can affect several segments. And because it has no proteolytic enzymes, the destructive changes may be very late in the disease. One thing, however, is important, that you see quite extensive epidural or extensive local abscesses, which are shown nicely here. So, and the final type of infection I want to talk about is coccidiomycosis, which is quite frequent in this area of California, especially in the Central Valley, where you see these focal erosive changes, which sometimes can look like tumors. Sometimes they can look like infection of the joints, like inflammatory disorders or secondary degenerative changes, which are shown here, where you have really extensive secondary disease now, but this was originally this was coccidiomycosis. Always here in California, an important differential diagnosis, and we always ask patients who have disorders like that whether they come from the Central Valley, where these spores are pretty frequently found. All right, we've made it to the end nearly. So you have your bill here, and we have to go over the just to take home points. So the point I made in the last 25 minutes is that you should be familiar with how degenerative changes in inflammatory arthropathies look like. Be familiar how to differentiate seronegative spondyloarthropathies from rheumatoid arthritis. Be familiar with findings related to gout, CPPD, tenosynovial giant cell tumor, and synovial osteochondromatosis. And be familiar with these infections, the types of infections, and these special infections we've talked about.